Welcome to PT 771, Scientific Inquiry 1 in Physical Therapy. In this particular presentation, we'll be discussing data analysis and how those results are important when we evaluate the evidence. And let's begin by discussing what some of the key steps are in managing a patient's primary concern. First and foremost, we have to accurately assess the clinical situation that we're dealing with. And that entails making an accurate and clear diagnosis. It also entails understanding the psychological and social impacts of the illness on the particular patient, and then finally negotiating an effective treatment plan given all of what we just discussed above. And so we're going to discuss how these steps can be utilized and how sometimes they may be overlooked in the appropriate management of a patient. And in the last slide, we discussed how important it is to make an accurate and clear diagnosis and then effectively negotiate an effective intervention plan with the patient. And we use the fundamentals of evidence-based practice for that. Our whole goal here is to improve patient outcomes. And we're going to do that by a couple of different ways. First of all, we're going to evaluate the best clinical evidence. And you are all learning how to do that in this course and others. We're also going to use our individual clinical expertise. You're developing that now. And then, of course, and maybe most important, are the patient's values and expectations. And trying again to negotiate an effective treatment plan, we have to ensure that we take the patient's values and expectations into account. So now that we've discussed some of those basic principles of patient care, including what's important with respect to evidence-based practice, let's see how this applies to a study that was published really some time ago now in the New England Journal of Medicine. And this paper looked at the management of patients who had low back pain, and it really looked at comparing three different treatments. One was physical therapy, two was chiropractic, and the third was just an educational book that was given to the patient, and the patient was managed with that. So in this particular study, 321 patients were included. All these patients had low back pain that was pretty much localized to the lumbar region. It's important to note that the vast majority of these patients had symptoms less than 6 weeks duration, and they were randomized into three groups. The first group was physical therapy, and the physical therapy group essentially got McKenzie-type extension exercises that are commonly used to treat patients with low back pain. The second group received chiropractic manipulation treatments, and then the third group just received an educational booklet. So they were seen by the physician and just provided with an educational booklet that helped folks understand what they can do for themselves with respect to low back pain. And they were followed for 2 years. And so before you move on to the next slide, I would ask you just think about this study, taking a fair number of patients, putting in one group in PT, one group in chiropractic, and then one group just getting an educational booklet. And just think about what the outcomes are likely going to be. Do you think one group is going to get better than the other? Or do you think all the groups are going to be about the same? And if there's going to be differences, when will those differences be seen? Early on in the course of care or longer term as we follow these outcomes out? In this particular study, the Rowland-Morris Disability Index was used to assess outcomes, and that was the primary outcome measure in this study. And if we look at the graph, we can see that when patients entered the trial, they scored about an 8 on the Rowland-Morris Disability Score. And again, higher scores on this particular scale indicate higher levels of disability. And you can see that from week 1 to week 4, there's a nice drop in the scores. All of the groups seem to improve, and then that improvement stayed pretty consistent over the course of the the 2 years of the study. And if you're looking to determine, boy, did one group do better than the other? They really didn't. One group wasn't really better than the other. Again, they started out all about the same, probably with a moderate level of disability, and then over the course of the next 4 weeks, as they're receiving treatment, the scores dropped, and then again they stayed the same over time. So there was really no difference in this study between physical therapy, chiropractic care, and the provision of an educational booklet. They got better, but then it stayed about the same, and really no difference between the groups. So again, with respect to disability, there really was no difference between the three groups. However, with respect to cost, physical therapy and chiropractic were significantly more expensive than really what it was just a single visit with a physician to provide the educational booklet. And if you look at the conclusion that the authors came up with, it really isn't necessarily very positive for these active treatments like physical therapy or chiropractic, right? They note that patients who receive this McKenzie method of PT and chiropractic manipulation really did not have better outcomes than those who received that minimal intervention with the educational book. And again, whether or not those small differences, clinically insignificant differences, are worth the extra cost, well, the authors really questioned that. And so again, this study showed that there really is no difference between physical therapy, chiropractic, and giving folks an educational booklet, and that these other treatments compared to the educational booklet were more expensive. And so again, there was some concern with this and potentially some negative implications for physical therapy and chiropractic. So an important aspect of really looking at research is looking at potentially what are some of the limitations of the study in light of the results that we just discussed. And take a moment and kind of think that through a little bit. What are some of the limitations in the study? What are some of the concerns with this study? Because again, if it's an insurance company that has these results, right, and all of you are spending a lot of money to go to physical therapy schools, learn how to manage patients appropriately, and if you're no better, right, than us just giving patients a book, right, and you're significantly more expensive, right, well, insurance companies may look at that and say, there really isn't a need for patients with low back pain to go to a physical therapist. And I get the chiropractic side, but we're most concerned about PT because that's what we are, and that's what our training is in. But really, chiropractic and PT were kind of in the same boat here, where insurance companies were very reluctant after this study to pay for treatment, especially if patients could get a book and get better. And what are some of the limitations of it, right? Well, I mean, we could talk about how these patients were managed, right? And so in this particular study, physical therapists were asked to just use the McKenzie approach, meaning that these patients just got extension exercises. I understand there's more to it than that, but in this particular study, patients were managed with an extension-based approach. And then for the chiropractic group, they were just told to use thrust manipulation on lumbar spine. And then again, the educational group, there may have been some benefit to that particular approach for some patients, but I think when you use one particular approach and you're not allowed to really migrate from that, you're really working against everything we talked about in those first couple of slides, right? We're not really establishing a diagnosis and then managing the patients or putting together an intervention plan that's based upon what our clinical findings are. In this particular study, we were asked to manage patients in a very particular way and really not deviate from that. And that's not always consistent with clinical practice. But for this particular study, those are some of the limitations that we see. As I mentioned, the chiropractic group in that particular study was just told to use thrust manipulation. And we know that thrust manipulation works, right, for maybe about half of patients with low back pain, right? Based upon this particular study done by Flynn and colleagues, we know that about half of patients, or 45%, are going to have a dramatic probability of dramatic success with thrust manipulation. So we know that if we use this particular technique, about half of patients get better, but about half of patients don't. And this particular study looked at McKenzie-based treatments, and if patients are matched to their directional preference, do the outcomes get better? And it showed that they are, meaning that if a patient has a preference toward extension and we treat them with extension, that's going to be better than treating them with something else. And that makes sense, right? We can think about that intuitively, that kind of makes sense. But this particular study also showed that about half of the patients after they were classified were in this extension group. Again, and so in that study we just discussed, if you're giving therapists the only option to treat patients with extension, again, only about half of the patients fit that particular category. There are other components, lateral movements and movements with respect to flexion, and then even some rotational movements that fit this treatment scheme. And so again, only about half of the patients met that particular movement pattern for extension that was used in that New England Journal of Medicine study. And then finally, we know that there is a group of patients that are likely going to benefit from this minimalistic educational-based approach, right? So if we look at this particular slide, we see that there are a group of patients down at the bottom of that triangle that are at low risk for chronicity. And for that particular group of patients, it may just be advice, reassurance, maybe a medication, an anti-inflammatory, or perhaps a pain-relieving medication, and maybe one visit of physical therapy just to help the patient understand probably what they should and shouldn't do, maybe give them some exercises, and maybe give them just some reassurance. And they're going to be fine with that, right? There are other patients, though, who are going to have the need for a more comprehensive plan of care, and that's that medium risk group. And then, of course, there's that group that's at high risk for prolonged disability. These are folks who have psychological obstacles to their recovery. Maybe there's some fear avoidance or some other concern associated maybe with depression, and we have to give these folks an enhanced package of care that really deals with some of that psychosocial overlay. So again, this is just to say that that educational book approach that we saw in that New England Journal of Medicine study may work for some patients, but not all, because we know that there are patients who are at medium and high risk that we have to give a greater level of care to. And so to wrap this up with this particular study we talked about, I think it's important to note that each of these treatment approaches probably has an appropriate time and place, right, for the management of a particular patient. Again, it goes back to those first couple of slides where we talk about evidence-based practice, and we talk about establishing an appropriate diagnosis and developing an appropriate plan of care, right, that the patient agrees upon, taking those patient values into consideration. We know about half of the patients may respond to extension exercises. Maybe about half of patients are going to respond to manipulation, and maybe about half of patients are going to respond to that educational minimalistic approach, and that's perfectly fine. But when you look at that type of a study and you look at those groups, within each group there are patients that get better, there are patients that get worse, and there are likely patients that stay the same. So you get this washout effect. So how would the results be different if patients were classified into those different groups? Would that make a difference? I think it probably would, and we'll spend some more time talking about that. So I think that one of the concerns that we may have in rehabilitation medicine is that there are these different schools of thought out there. There are therapists who do manage patients exclusively with a McKenzie type approach. There are therapists that only use manual therapy like thrust manipulation. And then there's likely providers who do take that minimalistic approach. I think that's fine, again, if the treatments are used for the appropriate patient at the appropriate time. But if that's all you do are those particular approaches, there's likely going to be times where the patient that you're seeing is not going to respond to that. And you need to know that you have to pivot from that particular approach to something else to get these patients better. And this is a brief paper that I have included for you for your reading for this particular lecture. And I would ask you to take a look at it. And it really describes some of the pitfalls of when we see physical therapists or other healthcare providers who just are so honed into that particular school of thought that they're trained in and they favor, and what some of the pitfalls from that could potentially be, right? This describes a patient who potentially had maybe mechanical low back pain, but had other symptoms associated with it and struggled with them, right, for a really, really long time, because many providers that he saw were trained in a particular school of thought and they didn't pivot from that. If the patient didn't fit that particular school of thought, the patient didn't improve, right, there were really no other options for the patient, right? And that's not necessarily the best way to manage patients. I think we'd all agree with that. So take a look at this paper when you get a chance. It's a quick read, but I think it's well worth your time. There's a couple of nice thoughts in there about how we can move beyond, right, some of the traditional management strategies that we've seen and get patients better quicker. And so we know in physical therapy there are varying schools of thought out there, right? And so we list many of them here for you. And it's not uncommon to see physical therapists who were trained in some of these approaches, right? Many of these approaches, just needs to be said, can be quite lucrative, where you take a series of courses and pay a fair amount of money to get trained in a particular approach. I think that's fine. I think that we need to ensure, though, that the approaches that we're training physical therapists in have some evidence to back those approaches and the techniques that they're being taught. Again, it goes back to that evidence-based practice kind of a thought that we want to use the best available clinical evidence, right, with our expertise and with respect to patient values. And so these schools of thought are out there. They're all great. Again, I think for the particular patient that fits that particular model at that particular time and place. But again, if that's all you're trained in is one particular school of thought, you may miss, right, the opportunity to make patients better quicker if they need some other approach. So out of all those approaches, who's right? Well, it's tough to say, right? If we had the same patient in front of us and we had 20 different physical therapists evaluate that patient simultaneously, assuming that patient didn't change each time they were examined, we may come up with 20 different plans, right? And there was a time and a place when everybody said, that's perfectly fine, right? We're physical therapists, right? It's an art, it's also a science, but that variability, boy, that's the art that's associated with our practice, and that's okay. I'll be completely honest, I don't know if I agree with that, right? We've talked about outcomes before with you, and we know that when it comes to low back pain, that's the #1 cause of disability worldwide. It's the most costly disorder to manage compared to any other condition. That's including cardiovascular disease and diabetes and diseases like that. So it's a very, very costly disorder, and it really causes a great deal of disability. And our outcomes haven't gotten better over the course of the past 20 years. And so I do think that there's probably a right way to manage a patient at that particular time and place. And so we'll talk more about that. But again, I think it goes back to your ability to find the best available evidence and using that in your practice, using your expertise, because that's going to be important, again, and looking at the patient values and expectations and what they want, right, with respect to their care. And I want to discuss one last concept before we move on to some strategies that may allow us to consider these different approaches, and when would we consider them. We've talked about evidence-based practice a fair amount already, and one of the areas there that matters is individual clinical expertise. And this particular systematic review looked at the relationship between clinical experience and quality of healthcare. And before you move any further in the talk, or before you read that abstract that I have posted here, what do you think the relationship is between clinical experience and quality of healthcare? Some may assume that clinicians who have practiced for longer periods of time provide better care and have better outcomes, right? That's where that expertise kind of comes in. But that's not necessarily the case. When we look at the evidence, we actually see an inverse relationship, meaning that the longer somebody practices, right, the lower their healthcare outcomes are, right? The poorer their outcomes are, and they're actually providing a lower quality of care, right? When we look at these folks who are practicing for longer periods of time. And why might that be? Well, if somebody comes out of school and they practice for 20 years and they're continuing to utilize, right, those same techniques and same strategies they learned 20 years ago, right, there may be some concern with that. And so that best available clinical evidence, that stuff is changing all the time, right? What you're learning today is not what we taught 10 years ago in PT school. Things are different now, right? And so we have to make sure that what we're teaching you is up to date and it makes sense. It makes sense from a research perspective. And so again, this talk is about evaluating evidence, right? If you're a clinician and you're not using evidence, right, in the management of your patients, that's when your outcomes are going to fall off a little bit. So again, the relationship between experience and quality of care is actually inverse. And especially if therapists or physicians, healthcare providers are not keeping up, right, with that best available clinical evidence. So we started this talk by describing that study in the New England Journal of Medicine that looked at those 3 different approaches to patients with low back pain, and that really there was no difference between them. And we provided a fair amount of evidence to you that certainly the right patient is likely going to respond to extension-based exercises or thrust manipulation or education, right? But there are likely patients that won't. And so in that particular study, right, they had a very, very broad inclusion criteria. Patients with low back pain, that was basically it, right? Patients with low back pain, they looked at different durations of time, and they didn't really say that we're going to just deal with patients who are acute or subacute or chronic. Anybody could be enrolled in that study as long as they had low back pain. And so when you take these rather broad or heterogeneous samples, right, with a lot of variability, right, and you use one particular treatment approach for them, right, and many of those patients you're already going to know up front are not going to get benefit from that. You're really not getting a true understanding of the potential of that particular intervention, right? Because only about half of these patients likely even have a chance of getting better with that particular approach. The other half are not. And so the true value of that intervention is likely going to be masked when we see these studies that have these broad inclusion criteria with large heterogeneous samples and one particular treatment approach is used, especially when that treatment approach is not necessarily geared toward all the patients in that group. And so one option, right, and we do this clinically all the time and we see it and you guys are taught this, right, is using classification. So we match a particular patient, right, to a particular approach based upon their history and their physical examination findings. And by doing that, it really decreases some of this clinical uncertainty that we see, and it really enhances outcomes. And so instead of just utilizing one particular approach for patients who have low back pain, can we accurately define these subgroups of patients that are most likely going to respond to a particular intervention? And I think that we can, right? Otherwise, right, we're just kind of throwing darts at a dartboard, right? We're using the exact same approach for all of our patients. And again, the true benefit of that particular intervention is likely going to be masked because some patients will get better and some patients won't. And so one approach to managing patients with low back pain deals with this low back pain treatment-based classification scheme developed by Julie Fritz and her colleagues. This has been around for several years, and you've been exposed to it already in your training in the PT program. And I think it's important to note that this approach is probably best for patients who have symptoms less than 3 or 6 months. Because when we look at patients who have symptoms for more than 3 months, at that point we start to see some of that psychosocial overlay kind of creep in. Not to say you can't use these particular approaches for that, but there's probably going to be some usefulness in using some other approaches, again, that have that psychologically enhanced care associated with it. And so using maybe some cognitive behavioral approaches or some other techniques that really get to those underpinnings that deal with that psychosocial overlay are probably more beneficial for patients who have pain for probably more than 6 months. And so this classification scheme is really meant, I think, for those more acute or subacute patients who don't have that psychosocial overlay. You can certainly screen for it, But the vast majority of folks who have acute and subacute low back pain are not likely going to have that, just because sometimes that duration of pain really leads them into that psychosocial concern. So anyways, these 4 groups make sense, I think, right, from a PT perspective. I mean, when we think about what does a PT do, we can do manual therapy, we can mobilize joints, we can do specific exercise. In this particular case, this deals with looking at if there is a directional preference, and if there is, right, let's utilize that to our advantage. We like to prescribe exercises for whatever the term you like to use, motor control or strengthening or stability, but we like to use exercise to get patients stronger. And then there's probably a group of patients out there who probably would benefit from lumbar traction. Right, these are patients who likely have radicular type symptoms, and they're maybe not responding, right, to that specific exercise, that centralization approach that we use with movement. These are patients who may have leg symptoms, or even maybe some neurologic signs with respect to strength, reflexes, or sensation, and we think that traction may have a benefit for that particular group. And so again, we're looking at clusters of findings from our history and physical exam, and we're going to try and classify the patient accordingly, and that is likely going to enhance outcomes. And this is a much different approach, right, than that New England Journal of Medicine study, where we're looking at patients, evaluating them, like we said on slide 2, right? We're going to evaluate these patients, come up with, in this case, a PT diagnosis, right, and negotiate an appropriate plan, right, based upon, again, our history and our physical examination findings. And of course, we're going to look at response to treatment, because if a patient isn't responding to our management, we need to move off of that in another direction. And later this week, we will discuss the usefulness of things like clinical practice guidelines. Those things are wonderful when it comes to the management of patients, because all the work has been done for us. And the most recent one that's been done for physical therapy was published in 2012. My understanding is there's going to be a new one coming out within the next year. But the bottom line is that when we look at the recommendations for physical therapy care for patients with low back pain, it includes things like manual therapy, directional preference exercise, trunk coordination strengthening exercises, and traction. Of course, there's probably a neuromobilization group in there somewhere. These are folks who are going to benefit from some of this treatment that's based upon neuromobilization. And then there's always a need for endurance and fitness exercises as well with many of these patients. And that's a nice place to go for most of our patients, because all of our patients, to some degree, right, can benefit from a good, sound, general exercise and fitness plan. And then finally, patient education. We do this all the time, right? And this is really the mainstay of much of our practice, educating patients with respect to how to move best, how to position themselves during functional activities, to optimize movement strategies, right? But at the same time, we are going to use manual therapy. We are going to use directional preference exercises. We are going to use some strengthening exercises when indicated. We may use traction, and we may mobilize the nervous system as well. But again, there's an appropriate time and place for each of these, and we're going to use our history, physical examination findings to ensure that we figure out where that patient fits best, right, to optimize outcomes. So let's take some time and try and apply some of this to a patient case. And so take a moment and read through this particular patient case. And then there's some questions on the next slide that I'd like you to answer before moving forward in the presentation. So after reading the patient case, let's go ahead and establish the patient's prognosis. What type of treatments would you use for this particular patient today? And then, are there any interventions that you don't typically use but would like to with this particular patient? So go ahead and address those 3 questions before moving forward. So with respect to prognosis for that particular patient, I think it's important to look at some of the literature and determine what are some of the factors that could potentially lead to this patient developing persistent disabling low back pain. And this chart, we present a few of those for you. The first and probably the most important predictor would be the presence of non-organic signs. These are essentially Waddell's signs. If you're not familiar with those, it's a series of tests that we can use with patients. And if these tests are present, it really indicates that there may be some lingering going on, or there could be underlying psychological concerns that are likely going to need to be addressed. And so if those are present, the chance of that patient developing low back pain that's persistent disabling is quite high. The other ones that we see are maladaptive pain coping behaviors. Again, this would be a patient who potentially has maybe some fear avoidance or some concern with movement. This is psychosocial overlay. It is not necessarily related to depression, but it's something that can certainly drive the outcome of the patient toward a negative direction. Also, two down from that, you do see psychiatric comorbidities. This would be like the presence of depression or anxiety, right? So the presence of depression is definitely going to influence somebody's outcomes who have low back pain. And then finally, baseline functional impairment. If that is affected, especially if it's affected by the nervous system, that's going to potentially influence disability. And so what we're talking about there would be perhaps loss of strength, severe loss of mobility, especially in patients who may be chronic, who may have neurologic system involvement. And then finally, low general health status. That's another one we need to be concerned about. So if patients have the presence of medical comorbidities, again, that could potentially influence that. For the patient that we described in that case, we really don't have all the information, but it's not necessarily evident that any of these are present. Right, so we don't think that there are non-organic signs there. She's generally pretty acute, and so the maladaptive pain coping behaviors, we mentioned that before, is something that likely is going to develop with someone who's potentially more chronic. We don't know if she's depressed, right, so we'd have to look more at that, but if she's not, again, that's another factor that would move her toward a positive prognosis. We don't have a great deal of information with respect to her physical impairments, but there's probably others we'd like to look at. But the bottom line there is that we don't think the nervous system is probably involved, and she's younger, and so her general health status is likely not a concern. And so in general, I would establish that patient's prognosis is probably pretty good. So it's interesting to note what treatments that you would recommend for that particular patient. That was actually a study that was done in the PT Journal several years back. They gave a group of therapists that particular patient case and asked them the exact questions that we asked you. What's your prognosis? And then what treatment would you do for that particular patient today? And so this chart provides some of that data for you. And it ranks the treatments based upon what is most recommended in those clinical practice guidelines. So for example, what treatment do we know has the strongest evidence of effectiveness for patients with low back pain? Right up there at the top, it's advice to stay active and advice against bed rest, right? So this is a patient who's already off of work, and so she's likely at home. We don't know what she's doing, but many times when patients don't feel well, right, they're laying in bed. And that is not something we want patients to do. We want patients to continue to be as active as possible. And so only 3% of physical therapists said that they would provide advice to stay active and advise against bed rest. Going back a bit to that study we talked about at the beginning of this talk from New England Journal of Medicine, I talked to you about this educational booklet approach. Well, the educational booklet that they gave them was a book that allows patients to really be set up for success because it has some of these thoughts in it. It tells patients, we want you to continue to move. We want you to avoid things like bed rest. Try and stay as active as possible. Continue to move within the limits of your pain, but certainly don't go to bed and lie down and just rest. It's not going to heal that way. And so unfortunately, only about 3% of PTs said they would do the treatment that has the highest evidence of effectiveness. What's the next strongest intervention? It would be manual therapy. So either thrust or non-thrust manipulation. And about 2/3 of therapists said they would use thrust or non-thrust manipulation. The vast majority here would use mobilization, which is non-thrust techniques. Only a very small percent, only 3 out of 100, said they would use spinal thrust manipulation. And then if you look at the treatments that have very limited evidence of effectiveness or no known evidence, right, that's where we see the majority of these treatments going. And so we see perhaps this use of modalities or treatments that really don't have a strong evidence base. We see therapists using that, the majority of therapists were using that, or they were using treatments with absolutely no known evidence at all. And so again, that's a concern because we'd like to see this flipped, where those interventions that have the strongest evidence of effectiveness, we would hope that physical therapists will be using that up front. And if there's a need for some of these other treatments, right, we can utilize them, but up front, we need to make sure we're using the treatments that have the greatest evidence of effectiveness. And unfortunately, that wasn't necessarily seen in this particular trial. So that example of a hypothetical patient case gives us some indication that PTs may not be doing those interventions that have the strongest evidence. And so is that reality? If we look at actual patient care scenarios, do we see those same things happening? And so this study, which was published in PTJ, looked at patients who went on to, patients with low back pain who went on to have surgery for their low back. And it looked at 588 patients, and they wanted to find out how many of those folks had physical therapy and what was done from a PT perspective. And so again, these are patients who went on to have surgery, and 1/3, 30%, had physical therapy. So on the next slide, we're going to talk about what those interventions were that those patients received. So of the patients that saw a physical therapist, on the left there, we have the treatments that were utilized, and they're listed by how often they were used. So exercise instruction, about 75% of patients received that. And if you look on the far right, that looks at two clinical practice guidelines that are being used. One's the American College of Physicians, and then the Cochrane Review is the other one. And so those are two recent clinical practice guidelines that have been published that have established whether or not these interventions have shown moderate or strong levels of effectiveness. And a plus would mean that it does show effectiveness. A negative sign would mean that it does not. And then you can see that whether it's unclear or they can't estimate based upon the current data. But you look at exercise instruction, that's what the majority of patients received. That's the most common intervention applied, and we see that all the time. I think it's interesting, of the patients that saw a PT, 25% didn't receive exercise. And then we see a variety of physical agents like heat, cold, stim, ultrasound, TENS. And it's unfortunate that we really don't know the effectiveness of those particular interventions. But we do know that soft tissue mobilization like therapeutic massage, as well as spinal manipulation therapy, those do have a sound evidence base associated with them. And so we see only 1 in 5 patients receiving some type of therapeutic massage, and only about 10% of patients receive spinal manipulation. And that spinal manipulation was defined as either thrust or non-thrust. And so again, this is consistent with what we saw in that last study about that hypothetical patient case, in that we do see physical therapists not necessarily using those interventions with the highest levels of effectiveness as often as they probably should. More commonly, clinically, we see treatments that are used that either don't have a strong evidence base to support it, or even in some cases, the evidence doesn't necessarily support its use. In this case, again, exercise was used, which is supported by the guidelines, but 25% of patients didn't receive it, right? So you'd have to ask, well, why did that happen? And so again, this is a concern. This particular talk is about analyzing the evidence, right, out there, and how does it drive clinical practice. And in these scenarios that we're seeing, there is a bit of a concern with some of that. So in those last two studies, I think the use of spinal manipulation was limited. Less than 10% of therapists were using that. Now those studies were a few years old, and so we redid this look at thrust manipulation, and we wanted to know how often and how well physical therapists are using this. We did it for a pragmatic reason too, that we sometimes teach you these techniques in school, and then you go out to your clinical internships and you sometimes don't see them being used. And so we really surveyed, in this particular study, our clinical instructors, right? So these are sites in New York State where physical therapist students would go to do their internships. And so we surveyed this particular group. And what did we find? Right, we found that about 40% of physical therapists are using some form of thrust manipulation for the lumbar spine. And then when you ask them how often they're using it, anywhere between 0 to 25% of their patients are getting that. And so it's 25% or less of their patient population is getting thrust manipulation who have lumbar spine problems. If you look at that particular sample, when we asked, well, what do you use to decide if you're going to use thrust manipulation? About half said they used a clinical decision rule, and there's one out there that you're likely familiar with and we'll talk about in a minute. So half used that. The other half weren't necessarily sure what they were basing their intention to use thrust manipulation on, which was a little bit of a concern. And then we asked them, does the New York State Practice Act allow you to do thrust manipulation? And it does. But unfortunately, about 40%, between 35 and 40% said that the State Practice Act does not allow them to do thrust manipulation. And so that's a major concern, right? Because that has been around forever. There may be one or two states that still have a practice act that limits the PT's ability to do that, but it's not New York State, right? So if PTs think that they can't manipulate because of a practice act limitation, that's a concern. And so who were the therapists that were most apt to do thrust manipulation? It was therapists who had board certification, who were residency and fellowship trained, who understood the practice act, and who had attended some type of continuing education course or two on how to use thrust manipulation. And so we think this particular type of study could have implications for how we would train PTs to use thrust manipulation, because we do think it's useful. And I'm just talking about thrust now. We could do this for pretty much any intervention. But thrust is one of those treatments that has been shown by these clinical practice guidelines to be effective, and it's been significantly underutilized in our clinical practice populations. And so why is manipulation and manual therapy underutilized? If we look back at that North Carolina study, only about 10% of therapists were using, only about 10% of patients had received some form of manual therapy. And that's completely being underutilized, right? We can utilize that with many of our patients, but the number one reason, especially for thrust, is concern over complications, right? That's the number one concern over that. Now, is that concern founded, right? We sometimes hear that from our clinical instructors, right? About 40% were doing it. The ones that were doing it weren't doing it very often. And if we ask them, why aren't you doing it? We're going to hear this. We're concerned about complications associated with the procedure. And let's talk about those on the next slide. So this is a slide that looks at different procedures for individuals who have lumbar problems. And you can see it starts with lumbosacral manipulation, then it follows on with exercise, non-steroidal anti-inflammatory drugs, and more invasive procedures, including injections and surgeries. And if you look at the risk associated with these, the risks of the more conservative treatments like manipulation are really, really low. Right, the one potential significant complication that we potentially see with manipulation is cauda equina, right? But that's extremely rare, right? Very, very rare. In fact, exercise probably has a higher risk of sudden death associated with it than somebody getting cauda equina from lumbar manipulation. Remember, we screen patients really, really well. We take a thorough history. we're good at evaluating risk, and we don't necessarily cross that line as PTs very often, right? In fact, I'd have to look really hard to find one case of a cauda equina case being caused by a PT doing thrust manipulation. If we look at NSAIDs, right, about 3 patients out of 100 are going to get a GI bleed that potentially could relate to death. And if you think about how many of your patients are doing things like NSAIDs, right, we get all of our patients exercising, but the risk associated with those procedures, and we're not even talking about the invasive ones now, are much, much higher than that with lumbar spine manipulation. Again, because the patient is screened really, really well, and we're very good at establishing risk and not doing procedures that are going to potentially cause harm to the patient. So in summary, spinal manipulation is underutilized. It's one treatment that's underutilized with patients who have spinal pain, and it's safe, right? The risks, the potential complications are really, really low. And again, this is a talk in evaluating evidence. I'm just talking about thrust manipulation in this particular case, because once again, it's one of the treatments that has shown to have a strong evidence base associated with it, and it's been shown to be safe, and it's been shown to be underutilized. And we're dealing with patients who have low back pain again, where it becomes chronic. The #1 cause of disability worldwide, and it's extremely costly to manage as well. So what patients would potentially benefit from spinal thrust manipulation? We started this talk by talking about that New England Journal of Medicine study where chiropractors who were very well trained in thrust manipulation, right, their results were no better than physical therapists doing McKenzie or that booklet, right? And so can we categorize or classify these patients who are going to benefit from spinal thrust manipulation? So this study done by Flynn and colleagues some time ago, this was the clinical practice guideline or the clinical prediction rule that was referenced by those physical therapists in New York State that we surveyed. About half of the therapists that used manipulation said they were using this particular rule. And what is the rule? Right, it tells us that there are 5 variables, right, that predict who's going to respond to thrust manipulation. So we're looking at duration of symptoms less than 16 days, no symptoms below the knee, fear avoidance belief questionnaire work subscale score of less than 19, at least 1 hip with more than 35 degrees of internal rotation range of motion. And then with our spring testing, there's hypomobility in lumbar spine. So these 5 variables formed the clinical prediction rule. Let's look at how it shifts probability with respect to outcome if these variables are present. So first and foremost, it's important to note that on the left there, about half of these patients who get thrust manipulation are going to have a positive outcome, right, within the first week. So they're going to get thrust manipulation technique. We're going to give them a range of motion exercise. We're going to bring them back in a couple of days. How do we define success in this study? If they drop by half on the Ross-Westry. So if they come in at a 50, right, they have to get down below a 25, right, to be deemed successful. So in this study, half of the patients had a successful outcome. We've already mentioned this before. We'd like that number to be better. We want more than 50% of our patients getting better, because if half our patients are getting better, that means the other half are not with this particular approach, and we can do better than that. So if 3 of these factors are present, right, if the patient has potentially symptoms that are more acute, less than 16 days, a lower fear avoidance score, no symptoms distal to the knee, lumbar stiffness with our central pressures, or good hip internal rotation range of motion, more than 35 degrees, if 3 of those are present, right, the chance of success goes up to close to 70%. Now that definitely increases our odds. So if 3 of these are present, the recommendation is go ahead and do thrust manipulation if it's safe. Right? If there's risk factors for the patient, right, don't do it. Do something else. But if the patient is safe and and the treatment makes sense, right, given your history, physical exam, and risk factor screening, go ahead and do the treatment, because these patients are going to benefit from it. And so what happens to the probability of success if we have 4 present? Well, now it goes up to 95%. Now it's a no-brainer. And so after you screen your patient and you're not concerned about metabolic bone disease like osteoporosis, right? You're not concerned about things like a fracture, right? You're not concerned about neurologic concerns, right? So the patient doesn't necessarily have potential underlying nerve root compression or cauda-equina already, right? And those are factors that would limit our ability to use manipulation with the patient. But if those factors aren't there and the patient, it's safe to do it, right? You have to do it in this case because, like I said, now the chance of success goes up to 95%, right? And so we can stratify and classify who those patients are who are going to improve with this particular technique. And we can do this with other treatments as well. And so this is an important finding because again, it really helps us determine who's going to get better with a particular technique. So again, going back to the beginning, we can establish a PT diagnosis and we can negotiate an appropriate treatment plan with the patient, right, with outcomes, right, a successful outcome really is our number one goal. So let's go back to this patient case. For this particular patient, especially in light of the manipulation clinical prediction rule we just discussed, right, what treatments did you recommend for this patient? We've already established that her prognosis is probably pretty good, just based upon some of the data that we reviewed and what we see here. Right. In general, the prognosis of somebody with acute low back pain who does not have neurologic symptoms is usually pretty good, especially if they're younger and healthier. Right. But for this particular patient, if we look at that manipulation clinical prediction rule, does it apply in this particular case? Well, we know her symptoms are more acute, and we know that her symptoms do not go down below the knee. Right. And so those are two key factors in our favor. We know that she has limited range of motion. We don't have palpatory findings with respect to spring tests or central vertebral pressures. But if we looked at that, it's likely that with that decreased range of motion, she's likely going to have some stiffness and some potential pain associated with those central pressures, which would likely, hypomobility, which would likely lead us, again, a third factor. So we know she probably has three factors. Right, she has acuity, no symptoms below the knee, and she likely is going to have hypomobility in her lumbar spine. So we know there's about a 70% chance, just with the findings we have here, of her having a positive outcome. If we just had that, I'd say it's worth it, right? If she's risk-free and there's no concern over contraindications, we should go ahead and do it. Right, we know that her hip range of motion does not recreate her primary symptom. Again, she's younger. She may have greater than 35 degrees of hip internal rotation. If she does, that's a fourth factor, right? That would take the probability up to 90%. What about fear avoidance? We don't know about that, and it's probably a good reason. There's probably good reason to assess it. She's off work. We don't know why. She's off work. Is it because she's fearful? If she is, right, that would be a factor that would lead us against thrust manipulation. But again, there's at least probably 3 here and potentially 4 if we look at the hip. And so this particular patient likely would benefit from thrust manipulation. Again, the other treatments that we know are important are going to be advice to stay active and her having and avoiding bed rest at home. So I think that that helps us kind of clarify this particular case. Are there other things you could potentially do? Absolutely, right? But I think that when we look at this patient and what would be the best way to initially manage them, in my opinion, based upon the data, I think thrust manipulation with a range of motion program would probably be best in the patient's best interest. So in this particular presentation, we started by talking about trying to establish an appropriate PT diagnosis and negotiating an appropriate plan of care. And that was based upon the best clinical evidence, our expertise, and the values and expectations of the patient. And we provided some data for you that shows that some of these commonly used treatment approaches, if we look at them in the literature, sometimes there isn't any evidence of effectiveness that one treatment is better for the other. Well, we think that classifying patients based upon their clinical signs and symptoms and what we find in our history and physical exam likely can change some of that, right? We can definitely prioritize what our intervention should be based upon some data that we gather and using the evidence to help us. In this particular talk, we use manipulation as an example, right? With our patient cases that we discussed earlier, and what's going on with some of the clinical instructors and some of the PTs that we see that a treatment like manipulation, which is backed pretty strongly by the evidence, is underutilized, right? And it's underutilized usually, maybe potentially due to lack of training, but the bigger concern is the potential complication with the patient. But if you use your screening skills and ensure that the treatment is indeed indicated and there are no contraindications, which all of you are really good at, manipulation can really help, right, shift those outcomes in a very positive direction. And so I think that as you continue to move forward in your career, I think that as you develop your expertise, you keep an open mind, you continue to look at the evidence, and that evidence really helps drive your practice. Again, with patient values and expectations always there in the forefront, right? And if you do that, you're going to begin to change that inverse relationship between experience and outcomes, right? So as you become more experienced and gain that expertise, right, your outcomes continue to improve over time. If you have any questions or concerns with the content, please feel free to reach out. Thank you so much for your attention.